everyone.
Welcome. Good to see you.
Thank you. So Jessica, let's when everyone is in.
Sure. On this platform, people are able to join freely, so whenever you're ready.
Okay, thank you. So good evening, everybody. Nice to see you once again on a Friday for our final day of UTC 7. So I'm going to be sharing the content. So if we remember what we covered last class, just before we finished, we introduced the module about management of suicide risk. And we talked about the factors that make people vulnerable to the risk of suicide. We talked about how to look for direct and indirect warning signs of suicide. So today we are going to complete that section by looking at the 4 steps process for intervention. How do we make an intervention when we encounter clients that have got a suicide risk? The acronym GATE or GATE is used to summarize the 4 steps. G stands for gather information. A stands for access supervision. T means we take responsible action. And E means we extend the action beyond the immediate action that we do. So what we have here is actually a big activity here that is supposed to be done in groups. And this activity requires that each group is assigned a step and reads the resource pages, and then they will make a presentation to the entire class. So we're going to be going to that resource page so that we can have a look at what that is about. So allow me to stop sharing this for now, and I can see whether I can share the resource page from your participant manual. So that's where I'm going now, to your participant manual. I wonder why it's sharing something different. So let me try once again. I want to share the participant manual.
It's page what?
Never mind, now I got it. Okay. I usually don't remember the page numbers. I just remember the resource page. So it is resource page 4.2. I hope we can all see it now. Can we?
Yes, we can.
Very well. So these are the 4 steps, which in your, when you go back to institutions, you're going to have your participants work in groups, and each group is going to look at each step, and they will make notes from these resource pages, and then they will present to the rest of the class. But we are going to just walk through each of these steps through these notes very quickly. So the first step is to gather information, and we are told that there are 2 main steps. The first one is actually the process of screening. If you remember, because the risk for suicide is real, we cannot wait to ask about it at assessment. We ask very early at the level of screening so that we are able to know whether we have any identifying warning signs or what we call red flags. So we screen, we ask certain questions to know whether we need to also ask follow-up questions to gather information, so that we know whether there is a risk, and a real risk that means we need to take certain action. So what do we do during screening? Remember, we said screening is a process of questions, often during intake. May I request that we mute our mics so that if you have background noise in your space, it does not interfere with us. So we said that screening consists of asking very brief questions. And I think I want you to pick that, very brief. They are generally uniform questions that we ask during intake, and we want to know whether there is a risk for suicide and whether we need to ask further questions. So below are some sample screening questions that you can ask. And there's something I want to say just before that sometimes people have this myth that if you ask clients about suicide, you might introduce that idea in their mind when it wasn't there. But research has shown that that is not the case. In fact, the reverse is true, that if someone was having fleeting ideas and you ask about it, they feel relieved that someone is ready to help them talk about it. So we should not be afraid to ask these screening questions. So these are examples. So for example, you can ask the patient, now I'm going to ask you a few questions about suicide, or you can ask them, I have a few questions to ask you about suicidal thoughts and behavior. So you can ask any of those questions to introduce the topic. So you must introduce the topic, because it would be also absurd if from nowhere you ask the client, have you ever thought about killing yourself? That's absurd, because you're going straight to the question without introducing. So the first question here is how to introduce the topic. So just like you remember when we were interviewing George in the ASI, we would tell him that, George, now I'm going to be asking you a few questions about your legal related issues. So we would prepare him. So the same way, we prepare our client psychologically for the questions we are going to ask about suicide. So after we introduce the topic, the second section, we screen for the thoughts. Remember in the last class, we talked about 3 levels. We talked about thoughts or ideation. We talked about plans. We talked about action or behavior. So here we screen for the thoughts, and then we also screen for any attempts, whether the client has made any attempt. That is what we are being told about there. Then the next part asks you to ask follow-up questions. And we only ask the follow-up questions if we got a response of yes in the earlier questions. If all the answers were no, then we don't need follow-up questions. So the first question is like a filter. If the client responds yes, now we follow up with another question, which helps us to get more information so that we have enough information to plan our intervention and to also guide the rest of the treatment team or the supervisor of the organization. So that's about follow-up questions. And there are some examples here. For example, if the client said they have been having some thoughts, a follow-up question could be, can you tell me more about these suicidal thoughts? Now, if the client requires more direction, because sometimes the client is not able to answer, you can guide them with the questions in point number 2, that what brings some of those thoughts, how strong are they, how long do they last? That kind of thing is what we are talking about. Then you can go on to ask about a plan. And in question number 3 here, we are asking whether they have any specific plan. Now, sometimes this plan may come in question 2, so that you don't then need to ask about it again. That's why you're being told if you do not already know, now you can ask about the plan. And beyond the plan, we also ask about the method. We want to know whether the client not only has a plan, but has access to a method. And the third point is whether they have an intention. Remember we said a suicide attempt is about an intention. Do they intend rather than just a coincidental? So we want to interrogate that to know whether there is a plan. How concrete is the plan? Is there a method? Is it a method that is accessible to them? So, for example, if they're talking about using pills, do they have them? If they're talking about using a gun, do they have access to it? And do they have the intention? So those are just some of it. Now, the second part now, we are going beyond asking about the ideation to asking about the past suicide attempts. So we want to know whether our client has had previous attempts. And so we ask them about it. We ask them to tell us more about what it was about, how they tried it, what is it that they used, were they, had they used a substance or were they substance free at the time? Where were they? What brought up that idea? We also want to know how lethal the method they tried was and whether, again, they had an intent. You can see the emphasis on lethality. Actually, the emphasis on the plan, the lethality, and the intent. That's very important as we are asking the client, because if the intent is very high, like Moses told us in the last class, then we know that we are in real danger and the client is in real danger, and we have to think about how to probably confine them in a monitored environment until they get over this immediate risk. Now, the second step after gathering information is to access supervision. Moses emphasized repeatedly in his presentation, in fact, it almost rings in my mind, when he kept saying, do not do it alone. These are serious cases, they are serious crises, and there are serious decisions to be made. So access supervision, access consultation. Be clear about your own institutional guidelines. What do they say in terms of who you should consult? What do they say in terms of who you should refer to? So think about all this as you are thinking of accessing supervision. Moses said it so many times that don't do it alone. look at your capacity. Does the institution think you have the capacity? Does the institution have someone else that you should refer the client to for further support? Does your institution have the capacity, for example, to keep that patient under 24-hour surveillance, for example? So these are the things we are saying you need to consult about, you need to ask about. I have seen situations where clients were working with counselors in certain institutions, and the clients actually committed suicide, and the families of the client started litigation on the institution. And it can be very difficult if you did not seek consultation, demonstrate that the proper mechanisms were followed of seeking consultation and supervision. And you can actually be accused of negligence besides just feeling the pain of losing a patient if there was something you could have done. So input from peers may not be enough. Consult a more senior person or a professional. Use the formal processes of the organization, which should be very clear in terms of who has supervisory responsibilities. Don't do it alone. I must emphasize, like Moses said. Now, sometimes we will need immediate supervision or consultation. Other times it doesn't have to be immediate, but it needs to be regular. So which are these circumstances? This is the first one. During intake, if the client exhibits direct warning signs, and now we remember what direct warning signs were. The client is communicating about it. The client is seeking a method which is very clear in their mind. The client is making preparations. Those were the direct warning signs. Then you will need to assess the client further with questions to see whether there is a current risk, and then the intervention you will need will require immediate consultation. That's what this is telling us about. So that is at the intake level. Now, during treatment, you might also require access to immediate supervision. If, for example, at intake there was no direct risk or there was no immediate risk, but as the client stays in treatment, then there is emergence of, again, direct warning signs. Now, then suddenly there is a current risk. So even if it wasn't there at intake and it developed during treatment, it is time to also access a consultation and supervision. That's what that is about. Now, the next one is telling us circumstances that can wait. You don't have to do the immediate consultation. You can wait and probably do what we call regular scheduled supervision. Sometimes in our programs, we have what is called regular scheduled supervision or consultation. For some people, it is weekly. For some people, it is fortnightly. I don't know what your program mechanisms are. But if the client at intake did not exhibit direct signs, but you picked some indirect signs, and when you looked at them, they did not indicate, when you did follow-up questions, they did indicate a reason to suspect a current risk. Then you don't have to seek immediate supervision. You can actually wait for the scheduled supervision and discuss about it with your supervisors or whoever it is that you discuss with. That is at intake. Again, during treatment, the client may also report development of indirect warning signs. Again, it does not require immediate access to supervision. You can actually have it in the regular scheduled consultation. That's what this slide says. But sometimes, if you're not sure, it is safer to consult immediately than to risk not consulting and maybe you missed a point or you missed seeing an immediate sign. The other step is step number 3, which is taking responsible action. What is this responsible action? Remember, when you have a suicide risk, it is a serious crisis. You have to use the guiding principle of making the best judgment in the situation. And like we said, one of the ways is through consultation, because when you consult, you're likely to have made a better decision than if you did it alone. So if you find that the client is likely to carry out an attempt, then you must take action immediately in the light of the information you have gathered. And there are many different possible actions here that are recommended for you. For example, you can arrange a referral to a clinician for further assessment of suicide risk, for mental health counseling, for medical management or medication management, and also to an emergency services provider. I am in the habit of never taking any suicide information lightly. and I always actually make a consultation, particularly with a psychiatrist. And I say that, one of the advantages psychiatrists have over counselors and psychologists is that they can actually provide medication to contain a client, which the psychologists and counselors cannot be able to do. So you might want to think about where do you refer your clients in your program so that they are in safer hands. Sometimes in our country, we have got some of the psychiatric wards, which are very well established in terms of surveillance, in terms of monitoring the patient. That the systems are very structured in a way that patients with suicide risks are well monitored. So it's safer to put your client in such an environment than risk keeping them in your small SUD treatment program, where even monitoring of that patient or that client is low, and the risk of them actually accomplishing or completing a suicide is high. So think about that. Restrict access to methods of suicide. This is important. You may need the help of family members or friends or whoever else is within reach. You can increase the frequency of care. If the client is an outpatient, do frequent telephone checkups. You can also increase the level of care where, for example, you refer from an outpatient to a residential or hospital-based treatment. You can involve a case manager. You can involve the primary mental health provider. You can also encourage the client to attend other meetings, enlist family members and others to support the client. And if the client signs come back, you observe the client for that return of risk. And I want to talk about the bullet on creating a safety card here, which is very important for the client, where you give them a card that in the event of acute suicidal thoughts, whom can they call? What numbers can they call? It's part of the safety plan, where you give them a hotline number, invite the client to contact you in case of acute suicidal thoughts, depending on the policies of your organization. So let's talk about this safety card. This card has got certain information. It has got a 24-hour crisis number if possible, the number and address of the nearest hospital emergency department, maybe your contact information, and the contact information of other additional supportive individuals that the client has determined with your support. Maybe a sponsor, maybe a supportive family member whom they can call. So that's important so that anytime the thoughts come and the reality of a suicide attempt is real, they can actually call a number on that safety card. And from time to time, you're encouraged to keep asking the client about that card. And sometimes they will lose it. And so you will need to replace it. So don't just make the one card you give them, keep copies so that when they lose that one, you can actually give them. And from time to time, ask the client to show you that card to confirm it's still there, and engage them to also agree on the willingness to use it when need arises, some sort of contract. So that is so much about the third step, which was taking responsible actions. Then the fourth and final step is where you're advised to extend the action. Why are we extending the action? Because a suicide risk is an acute problem, which is a crisis that we deal with immediately. But there's a danger in assuming that when you have contained the immediate risk, the problem is sorted. Not at all. Remember, there were reasons that were causing the client to attempt or think about suicide. There are factors. So we have a responsibility beyond that immediate crisis intervention to extend the action, to look at the bigger issues that were underlying the context of the client's suicidal ideation. So that is what this is about. So we keep monitoring the client for signs of return of the risks. We address the underlying issues so that we are not just addressing the acute stage of the crisis. Now, examples of extending action include confirming that clients is keeping referral appointment. If, for example, you refer them to a mental health professional, many of them will drop out after that, after the crisis is over. So it's your responsibility to keep in touch to find out whether they are continuing to go to their sessions, continuing with their medication. That's part of case management. You can also coordinate with the mental health provider, more of case management, like we have said, and also keep checking on the client for any recurrence of their suicidal thoughts or ideation. Also keep checking whether the client has a safety card. Check with family members whether they are observing any recurrence of or change in suicidal thoughts. Of course, you reach out to family members to keep them engaged in the treatment process beyond the immediate crisis. And sometimes even the family itself becomes affected psychologically. So offering support to the family so that they can be able to continue supporting the client is part of what you can also do in terms of extended action. Now, finally, we want to look at this next section, which was in our slides. It is about the decision tree. How do we assess and make decisions around issues of suicide? So how do we assess and address suicide risk? This is a decision tree, which hopefully will help us to remember what we should do. So the first step, like we have said, we screen for warning signs. We screen for risk factors, like we said. So if there is no risk on the left here, then what do? We just continue with monitoring for the warning signs, which we already know, and then we keep checking whether there is risk or risk will come, right? Especially if the client may, and like we said in the last class, SUD in itself is a risk factor. So we need to consistently monitor our clients, even when there is no warning sign or risk at the moment. It could actually develop. I remember a client who was a university student and had been using cannabis, developed psychosis, went for treatment, and they were in a detox center for some time. Then they were discharged, having, according to the treatment provider, recovered or stabilized. But they actually developed suicide ideation after that. And that became an even more serious problem than the earlier one. So they had to be hospitalized for about 2 months because they were finally even diagnosed with bipolar disorder. So it is important, even when we don't have warning signs and risk factors at the intake, to keep monitoring just in case this can come out. Now, what if there is a risk? What if at intake we see there are warning signs, direct and indirect? What if we see there are risk factors which are high? Now we gather more information, then we assess whether the risk is current. If it is not current, again, we go to the left. We then access regular supervision. You notice this is regular, not immediate, and we take action as appropriate. But if we assess and we realize the risk is current, it could happen here and now. The client has a definite plan, the client has access to a method, the client has an intention. Then we take it as a current risk, and so we go in this direction. We seek immediate supervision or consultation, then we take appropriate action. So in both, we are seeking some supervision, but when the risk is not current, we seek regular consultation. When the risk is immediate, we actually access immediate supervision. For both, we actually take appropriate action, and at the end of it, we extend the action like we have said. And of course, we continue to monitor and strengthen what we are calling the client protective factors throughout treatment. We have already talked about that. We do case management. If we need to involve other treatment support for the client, if we need to mobilize family support, if we need to mobilize, what do we call it, peer support. So we bring in all these, we build all this recovery capital for the client as part of extended action. So let us keep in mind this decision tree when we work with our clients. So that I will stop there, and I'll go back to the other slide, the PowerPoint, so that we say one more last thing about working with this client. So that's the decision tree we have just looked at. So the final part of this presentation is emphasizing the importance of documentation. In fact, you can see that the part in purple at the end says, if you don't write it, it is as if it did not happen. So we must document. Remember, we talked about in UTC 5, the importance of documentation. And you remember there were many things we said that documentation helps us to do. So in this specific topic now, we're saying that we need to document that we assessed the risk for suicide in our client. We need to document that we sought supervision and consultations. We need to demonstrate the action that we took and the justification for each of these actions. So for example, if you took immediate consultation, you took the client, immediately referred them to a mental health provider or a psychiatric, for example, or you took them to a psychiatric hospital or to any other hospital or residential treatment, what was the reason for doing that? And then finally, we must also document what follow-up actions did we take. This is important in case the client eventually does commit suicide. We can document, we can produce our documentation and show, indeed, legally and ethically, we did the best we could to save that client's life, because we did assess the risk. Maybe the risk was low or there was no risk at that time. So we did what is called continuous monitoring. Then we did supervision, which is periodic. Then we took the actions as determined, and then we followed up. Or we did assessment, the risk was real, it was current, so we sought supervision immediately and consultation. We agreed to refer the patient to a psychiatrist for medical treatment. And after that, we followed up with case management, and we are continuing to build the recovery capital of the client. So in short, what we are saying, considering that we said all our clients with SUD have some level of risk of suicide, because SUD in itself is a suicide risk factor. Again, if you remember all the other suicide risk factors we gave, all the way from co-occurring disorders, issues of stressful life situations, our SUD clients will actually have all these combined. So it is important that we are continuously not only screening for risk at the beginning, but using follow-up questions, not only at intake, but also at different points in our treatment programs. So if you don't write, it did not happen. And there is also a resource page here, which you can actually refer to at your own time. So thank you very much. And I wish to stop it there. And I will now give it up to, I think it is Moses. Yes, I think it's Moses, if I'm not wrong.
Yeah.
Take it up from there. Thank you.
Beatrice. Okay. Let me go ahead and share. We're going to module 5 now. Okay. We'll continue with module 5, avoiding personal crisis, counselor safety, and self-care. No, we're talking about how to, assess and take steps to prevent clients from committing suicide. But the counselor too needs to take care of he or herself. At the end of this module 5, we'll be able to discuss how to make counseling settings safer, discuss how to avoid unsafe professional situations, determine personal and professional stressors and supports, and create a plan to increase self-care and avoid burnout. Counselor safety issues. Studies in the US from 1986 to 2004 have come up with this statistics we have here. Clients in SUD counseling can become angry or even hostile in the United States. It's got that they reported that 49% to 81% of counselors report verbal or other non-physical threats, and 12% to 40% reported physical assault. And most physical assaults resulted in no or very minor injuries. 30% resulted in any injury, and 10% in moderate injury. This was United States. But for those of us who work in treatment centers where you don't just do counseling, but you do pharmacotherapy, and sometimes the figures might even be higher than this one. And so you have to actually watch out and take care of yourself and prevent yourself, from getting into harm's way, even as you try to help your clients. So these are statistics from the US. What are the guidelines to effective communication when you're counseling clients who are in crisis situation? You have to listen carefully and patiently. Yesterday, I told you about one of my clients who called me and told me he wanted, to commit suicide, and he was thinking of 3 ways of committing suicide. He wanted advice from me, which would be the best method for you to commit suicide without pain. And what happened was that he was in a crisis because he invested some money after he retired, and he discovered that his business was not thriving, and somebody very close to him duped him. That was what triggered of the crisis situation. So I had to listen carefully and patiently before I started engaging him, and I had to help him out. Be empathic and do not judge. Because most times we might not be patient enough, and we don't, try to put ourselves in the client's shoes. And the first thing that comes into our mind is that we judge. Why would he do that? Doesn't have faith. That's what they would say in my own environment. Oh, he's an ungodly person. He's not a serious person. He's a joker. That's what they would say in my environment. But you have to be empathic, and you must not judge. Do not take a client's anger or frustration personally. Sometimes they come and they're so frustrated, they are angry, they display all their frustration and anger at you for just no reason, no justification for that. But if you take it personally, then it's going to mar your therapeutic relationship, that rapport that you have. But you have to be calm, you have to compose yourself and listen to them and help them to ventilate. And then you can maybe ask questions to clarify why they're so angry, why they feel so frustrated. You know that they're in a crisis situation. So if you take it personally, you will not be able to help your client. Avoid overreacting. Remain calm, rational, and professional. Yes. Sometimes some of us are always, very aging, and we overreact to minor issues. These are issues that we have to deal with and don't cause more problems for our clients. Must be able to remain calm, compose yourself, and also be rational in your approach and professional so that you can help the client. There are times that they will come very aggressive, and in fact, in displacing their anger, maybe they are even fighting with another client, or they have conflict with some other clients. For those of us at the treatment centers, then they just displace all their anger and frustration on you. Sometimes they go and smash the windscreen of staff vehicles for just no reason, or they take it even upon the staff. But the problem was not, did not originate from the staff, but among themselves. So if you take it personally, you'll not be able to help the client. And the guidelines to effective communication continue. Be aware of body language. And every counselor, every mental health professional should be able to talk to the client and also watch the body language, the movement, and the tone of voice, everything. Because the client may be saying something differently, and the body language is saying another thing. But most times they're not aware of their body language, and they may say something. But if you watch the body language, then you'll be able to take the necessary precaution and be able to help. Respect personal space for you and the client. And in our culture, you must respect this personal space, particularly if you are dealing with a client of the opposite sex. They can be very shy, and if you get too close, you'll be threatening them, and they will not be comfortable, and that can aggravate their situation. So respect personal space for you and the client. If you made a mistake, admit it. Sometimes it's difficult for young counselors or trainees to actually admit it when they make mistakes. But for those of us who are in treatment centers and we incorporate some elements of therapeutic community, it is not difficult for you to admit mistakes, because one of the principles is that you'll be able to admit your mistakes, you don't give excuses for them, and when they point them out, you only apologize. and admit, but don't defend yourself. Don't give reasons, even if a client points it out to you. And for those of you working in this kind of setting, even myself as a director can be corrected by a client, and I don't take it personally. I just admit and apologize if I think I'm wrong. Review and clarify what the client needs. Yes, what do they need? Review and clarify. Sometimes they are confused, they are angry, they are tense, and they may be saying so many things at the same time. You need to clarify. You need to review and clarify so that you are communicating with the client and you know that you understand their situation. And define your role and limitations and what you can realistically do for the client. Don't give some false hope or assurances that you know that's beyond your own capacity to provide for the client. But define your role and know your limits and when you need assistance, when you need to consult your supervisor, and what the program rules and regulations, say, and try to be as realistically as you can, as realistic as you can, so that the client can learn to trust you and have some confidence in what you're doing. And clarify messages, ask questions, and reflect. Because they might give a message that is confusing to you. Do you just take it, that way, or you need to clarify? You need to reflect. You need to paraphrase, and ensure that you get it right. So that if it's not right, they may clarify for you and ask questions and reflect. Don't assume that you understand. Let the client also know that you've actually understood them and you're not really in a hurry, but you're there for them to support them and give them some listening ear and support. And let clients know you are trying to understand their feelings, how they feel. Don't underrate them. Don't minimize them. Don't exaggerate them. But ensure that you let them know that you understand their feelings and where necessary, you'll be able to validate their feelings, as you said yesterday. And let clients know you are there to help them. You are there for them. You are not trying to run away. You are not in a hurry, or you are not snubbing them. And ignore challenging questions. Sometimes they may bring irrelevant questions, and they do that particularly to young or inexperienced counselors. They bring challenging questions, and in our own environment, you find that those who are really very educated or those who are older tend to challenge younger counselors, and particularly those who are single. They challenge them a lot, and sometimes they bluntly refuse, to seek help from them, and they want an older counselor or a more mature person, to talk to them. So if you think you are not able to offer help, then refer them to somebody who's experienced or who they trust, because there are a lot of cultural issues here. Sometimes some of my other clients will just refuse to have anything to do with younger counselors, or maybe you have a university don who comes and he said this one was even my student. No, I can't go with such a person for counseling. And you call them, they would never. In fact, they use a lot of passive aggression. They don't even respond. They don't go at all. That's why in our environment we try to match counselors, to clients because of cultural factors. I know some counselors will never make any headway with particular clients. So there are times that I have to step in personally. And for some of them, if I don't go there, or my deputy, or some of the consultants I can't don't go, they will not even bother, to see other younger people. So you know the sentiments and you'll be able to tackle such things. But ignore challenging questions and just redirect them to the issue at hand. It can be very difficult, where we practice here. if you don't understand the culture. And make your setting safer. Well, I don't know, maybe I would like to hear from uh, participants. Does anybody have anything, maybe in your own practice or your own experience, you have one or two things that you want to add to this guideline to effective communication? Let me hear from one or two participants. Maybe you have some experience in this and you want to add one or two things that I have not said here. Please, Jessica, help me out.
Yes, I'm looking for hands.
I want to learn from your own experiences.
I don't see any yet.
Okay. All right. If there's none, let's move on. Make your settings safer. Remove objects that could be used as weapons. In my own place, in fact, we ensure that we don't have anything like rocks or metals close by. Even their plates and their cutlery, we prefer hard plastic to the metal ones because of our past experiences. Sometimes they can just fight among themselves and then enjoy themselves. So because of that, we ensure that whatever they are using is maybe hard plastic, not metals, just to ensure that there's safety. Because if you have newer clients coming in who are still settling, they may be so confused, they may be aggressive, and some of the clients might have anger issues that they're dealing with, and they may not be patient enough, and before you know it, a fight is breaking out, and then they can become extremely very destructive. So we try to remove objects, that can be used as weapons. Even in your office, in our offices, we make sure that we remove any, and if there's a metal, you take it away. That can be easily used as a weapon. And even if you have a drink, we prefer hard plastic, than bottles, because you don't know when a client can reach out and pick a bottle and smash your head. So you have to be very careful. Arrange seating so that you and the client have clear access to an exit. Well, this is basic teaching in mental health, that you must have a way of escape, so that you are not trapped by the client. Sometimes they come, they are confused, they're in a crisis situation, they're delirious, and they see you as far as an enemy coming to attack them, and they can use anything, against you. Even when you have not even settled to ask questions, they become very, very aggressive. So you have to ensure that the seating arrangement is such that you are not boxed into a corner, but you have, access to an exit, and also for the board training. Some of the counselors had not had to rearrange their sitting position in their offices. It's the basic thing, the first thing they teach us when we're interviewing clients in psychiatry. I have a method of communicating with others if you need help. You must have a method, whatever it is, whether it is a bell, whatever, that you can signal that you are in danger and communicating with our colleagues or other staff, to come to your help, or the security staff to come to your help whenever you are in danger. But uh, don't take things for granted and get into danger, because the clients can be very, very aggressive, particularly in our environment. If client is at high risk for violence, meet where you can be seen or heard by others. And I keep stressing that to my female counselors, and particularly if I know that the client is aggressive, I ensure I check that they are safe, so that they don't get injured by some aggressive clients. Pay attention to gut feelings of threat or danger. So if you have a feeling that the client is aggressive, because sometimes they will try to conceal everything and they just take you unawares, off guard, and maybe pounce on you or attack you, or do many things. And some uh, staff have been physically assaulted before by clients. you know. So you have to look at the body language, and if you have gut feelings that this client might be aggressive or you are in danger, please don't just ignore it. Take action so that you don't run into danger. And evaluate for risk of violence factors. Usually, when you are doing assessment or you are taking history, you should be able to uh, collect some information about past violent behavior in the client. This is very important, particularly when you are dealing with clients who use substances. Sometimes some of them would have even come, to seek information, and you tell them that they will need to come in. They tell you, no, I'll come, but they will not come. And they say, I don't think I have a problem. I'll come but when they run into problems with the criminal justice system, particularly because of some violent behavior, they say, I've seen Dr. So before, because of drug use. So they want to use that, as a defense. So some of them have, and sometimes you have to go to the police station to be able to help out and to get the clients into treatment. And behavioral problems, especially aggression in childhood or adolescence. History of aggression in childhood or adolescence is very important. And some of them will not even want to tell you, except if you are skillful, you are able to establish rapport with them, and they trust you, and that you have that trusted relationship, then they might open up to you. They might open up to some staff, but to some other staff, they will not open up to them. So you have to do your best to collect all the information you need about aggressive behavior. But since we are running a treatment center, you get information from every source. The nurses will report to you that they about the way they interact with other clients and staff, or even when they go to the kitchen to get food to eat, whatever. The security staff will report to you. The cleaners will report to you. So you get information from various sources. So even when they attempt to conceal information, you still get feedback that they are actually very violent people. And the history of arrests, you should get to know that. Why were they arrested? Maybe for some violent behavior, particularly when they are under the influence of substances. But normally they are okay. But once they take the substances, some of them can become very, very violent, particularly when they take things like alcohol, cocaine, so on and so forth. And then having been a victim of violence, because violence begets violence. When people are being traumatized and don't do anything about it, they are likely to, become victim of trauma again, and they also are likely to traumatize people, except you work on them or you conduct trauma healing on them. So it's very, very important to find out from such people, and it may be even a history of being a victim of violence that might make some of them even go into substance use. So it's very important that we carry out a thorough assessment to know, our clients very well, and must have that high index of suspicion that we're dealing with clients that sometimes can be very unpredictable. Evaluate for risk of violence, past risk factors continue, personality disorders. When you do your assessment, for instance, in our center, we do all the ASI and so many other assessments. Then uh, psychologists also do further assessments, look at personality factors and personality disorders, and the psychiatrist also, does a thorough mental health assessment, and to be able to determine maybe as it's one disorders for the diagnosis and whether there are other personality disorders, so that you know the kind of client you are dealing with, and serious mental illness. Yes, sometimes they might deny issue of mental illness, particularly if they have no insight into their problems. But you still be able to get it from collateral sources or from reliable informants. And then brain injury or cognitive disorders. Yeah, they might have brain injury might have been violent and may not even recall that they have ever had a violent episode in the past because they are failing cognitively. So you should know and be able to take precaution. And then unstable relationships. There might be in unstable relationships, and maybe because of their violence or these risk factors, they have not been able to sustain relationships. So they have always been unstable, and it might be because they have engaged in failed relationships that they have also become, violent because they can't cope with uh, with this stress, of failing relationship. So you need to be able to get this, you know. But it doesn't mean that everyone who has maybe a personality problem, or serious mental illness, brain injury, or cognitive disorders, or unstable relationships must necessarily become violent. But if you have a cluster of symptoms, then you must have high initial suspicion that they are likely to become violent and take precautions so that you help the client and help yourself and help others who might be injured or may run into trouble with the client. The good thing is that sometimes the clients who have stayed longer and have recovered to some extent, understand this, and even when the clients become uh, violent or aggressive, they are able to understand with them, they're able to help them out, and they're able to contain them, in a gentle way, and help them out. And say, and sometimes I say, I'm really uh, impressed that you're able to, keep your calm even when you are physically assaulted. They say, yeah, no, no problem, doctor. I came that way, so I understand that this client is in a crisis situation. So I understand, and you affirm them, and encourage them, to keep up with that behavior. Uh, Evaluate for risk of violence, current risk factors. The patient or the client might be angry or hostile in their behavior, and the emotion too may be extreme. They may be agitated, they may be severely depressed, or they may be, hyperactive. They may be extremely very angry and fuming. You must find out what's happening at the moment and whether there's a current risk or not. And the acute symptoms of mania, schizophrenia, or other psychotic disorders, or delirium, like hearing voices saying to harm others, or parallel delusions, can lead to a lot of violence. And most times, clients might commit a lot of violent acts or become aggressive towards others, and they don't even recall. And sometimes some of them may even suffer from seizure disorders, and they become very violent and destructive, but they don't have any recall. They can't recall what actually happened, but it's usually episodic. So you need to be able to evaluate. There are times that some clients use substances and they also suffer from seizure disorders, and they be involved in very violent acts, and they come and they say you did this and that, and they have not. That is this inkling or memory that they actually carried out, or committed such acts. So that may suggest to you that the client might be suffering from seizure disorder. And most times we get referral to from physicians to say that the client is mentally ill, but in reality, some of them are not really be mentally ill. It's just that they have seizures, and during the episodes, they can become violent. And first of threats of violence, they might be thinking of violence, or they may even be threatening. It's up to you, to be able to elicit these symptoms and help the client. If you don't, then you might miss some warning signs or some telltale signs might be uh, might be exhibited before you, but you don't actually give consideration to them, and eventually you find that you run into problems. And it's only after the act has been uh, committed that you say, "Oh, if I had known, I would have, taken this threat or even paid attention to, this violent thoughts that the clients are muted out." So you need to know that you are working with people that can become violent, particularly those who use substances. And post-therapeutic alliance, where there's a lot of difficulty establishing, a therapeutic alliance with some clients, or poor response to treatment should be an indicator that this client can become violent. Sometimes they are just being defiant because they are set by the criminal justice system or they opted for treatment, or maybe because of threats by their guardians or parents that they are going to disown them or to kick them out of the house. So they decide to come. And when they come, uh, in that situation, they can be very aggressive, violent. I recall one who smashed a staff a windshield in the parking lot, and we asked him why he did that. He said his father asked him to come for treatment, and we can go and meet the father. The father has money, so he wants you to spend the money in fixing the windshield since he thinks he has so much money to pay for him, to come in for uh, treatment as an in-client. Then he's ready to make him spend as much money as possible, and that was just the reason for smashing, the staff's windshield. So what do you do with such people? And of course, the father had to pay. So access to weapons. Make sure that there's no weapon, anything that can be used as weapon around. And I've had clients my own clients, who were in crisis situation. And what they did, in fact, two of them, what they did was that they they went to a checkpoint manned by soldiers, armed, and then they got there and then tried to snatch the guns from the soldiers, in their own crisis situation. And luckily, they were just physically assaulted by the soldiers, and then they were brought in, for treatment. When one of them, recovered, I asked him why he did that. He said he was fed up, with life, and actually he wanted to die, and he believed that if he attempted snatching a gun from a soldier, he'd be shot, and at least he would die. He would not have to live again, and he really wanted to die. That's why he did that. So when I asked him after, I said, "But do you still want to die? Do you still have this suicidal thought?" He said, "No." "Are you enjoying life now?" He said, "Yes." But he was severely depressed at that time. So when they have access to weapons, they can do anything. And three of my clients have actually done that to soldiers at checkpoint, at young men who attempted to snatch guns from soldiers. And then impulsivity. When they're impulsive, they don't think. It's just like you shoot before you take an aim. So they don't reason, they don't think of the consequences of their actions, and they can just do anything anytime. So when a client is very impulsive, you know that he might easily run into trouble, and he's not able to control their impulses, and they can become aggressive, towards people. And poor compliance with treatment, future risk factors. You must envisage that this client that you are treating might run into problems because of poor compliance with treatment. There's history of, discontinuing medication, and each time you try to talk to our medication adherence, doesn't really make sense to them, and they fail to do that. And the lack of social support, which you have to really build as part of their recovery capital, and peers who support criminal aggressive behavior. Yeah, there are peers who support criminal aggressive behavior, and for us, you find that they have a tendency to gang up. Once there's an aggressive episode, they have a tendency to support the aggressor and to disrupt the system. So you constantly have to be on your guard, working, to ensure that there's no ganging up, and there are no, aggressive episodes in the treatment facility. And some of them have unrealistic plans. When they have unrealistic plans, they can easily get frustrated because those plans will not materialize. So those ones can display their frustration, you know, in aggression. And then impending losses can also lead to violence and aggression. So these are things that you need to uh, think about, and you'll be able to plan for them. You know that in the future, this client I'm canceling is likely to run into this kind of problems, and see how you can help them out. There's small group exercise here, increasing counselor safety. In small groups, we are supposed to, brainstorm about a list of ways to make counseling safer, but we are short of time. And what precautions do we take? For instance, before a session or during a session and after a session, it's supposed to be an exercise. Maybe we'll post that as an assignment. But I don't know if anyone wants to share with us maybe their own experience, what precaution you think you need to take after listening to this talk. You want to take before your own sessions or during your own sessions or after sessions. I want to hear maybe from a participant before Beatrice takes over. Please, Jessica, help me out.
It looks like Titilope would like to share.
Okay.
Okay, I want to share during section. I'll make sure I have a safe distance. Be alert all through. I wouldn't argue with my clients. I wouldn't be judgmental, and I will try as much as possible to make sure the distance is very appropriate in case you want to escape in case of danger.
Yeah. Thank you very much. Yes.
Thank you.
We need to take some precautions. So there's a reflective exercise here for us. You create a plan to improve your own personal safety as a counselor. You consider how safe is the setup of your office. Does your program have procedures for calling for help? And what steps could you realistically take to improve your safety? You can reflect on this and write it so that when you go back to your own place of practice, you know the changes you want to make, having had what we have discussed this evening. That will help us. And also, we help you to be able to teach it to your students and those who are actually supervising. We need to take precaution and make sure that the counselor himself is safe, even in as much as we work for the safety of the clients. We have to take care of ourselves and others who might be in danger because of the behavior of our clients. And remember, we're talking about crisis situation. When people are in crisis, they don't think much. They can become very aggressive and they can do many things that you never even expect. Thank you very much for your listening and active participation. So I'll hand over to Morocco now.
Thank you, Professor Moses. Good evening, colleagues, participants. I'm hoping that we are all alert because I know it's Friday. So let me just share my screen with you. We are continuing with counselor care. Just the current slide. Can we see the slide?
Yes, we can.
Yes.
Okay. So I'm hoping that all of us are awake because there was a question that was asked and just there was no response. So I'm going to make sure that we are awake throughout until the next 15 minutes, 30 minutes. So moving from what Moses just talked about in terms of effective communication and what to do and how do you go about assessing risk. One of the things that is actually very crucial in terms of SUD treatment is the aspect of counselor self-care. And I know that a lot of times this is somehow neglected, and so I would want us to pay very much attention to this discussion, because a lot of times we find our counselors being burned out in terms of doing treatment because they do not take care of themselves. We know that counseling for many is rewarding. When you have a conversation with people that are in the profession, they often speak more to the rewarding aspect of counseling. And the common one factor is that it's actually them seeing the transformation of their clients. That is the most rewarding aspect about counseling for most counselors. Though it is rewarding for most people, it actually has a lot of difficulty, it has a lot of distress. And there are a lot of reasons as to why counseling can actually pose challenges to some of our counselors. Number one, it's actually working with the clients themselves. As Moses have already pointed out, sometimes we work with clients that have very serious issues. It could be because of violence. We've talked about the fact that our clients sometimes have co-occurring mental and medical issues. They could have serious family issues. So we do have clients that actually present with a lot of issues besides SUD, making it very challenging sometimes for us as counselors. Sometimes they do have difficult behaviors. I think, as already said, when you have clients that have SUD that are violent, you need to be more cognizant of yourself and aware of yourself and how to actually interact with the clients. Because of the difficulty of the behaviors that are often exhibited by our clients, counselors may experience many emotions. The emotions that counselors sometimes experience is due to the fact that we work with different clients who have different personalities, and therefore sometimes they evoke emotions in us because of their own issues and transferring their own issues onto counselors. How do we then go about actually addressing this issue of working with difficult clients? One of the ways that has been mentioned before is actually making sure that counselors seek supervision. I know there are scheduled supervision, but sometimes when you find yourself in a corner or dealing with a client that is very difficult, you can actually consult, you seek supervision so that you don't find yourself very overwhelmed. The other distressing factor is actually counter-transference, which comes about by listening to clients' problems and feelings, and therefore bringing up your own thoughts and feelings as a counselor, that is in the past and present life. The issue of counter-transference for counselors is often actually dealt with in clinical supervision, and sometimes, and most times actually, it's often recommended for such issues, counselors should actually go for individual therapy themselves so that they can actually resolve their own issues that might actually impact on the effectiveness of doing therapy. Not only is it about working with clients, the work environment, SUG environment, actually itself can be a source of stress. Expectations may be unreasonably high. Sometimes in programs, they have a quota in terms of how many clients they have to serve. And therefore, that expectation can actually be taken upon on counselors. I know I've been in programs where there is sort of a strategy that is already there. How many people are we supposed to see in 3 months? How many people are supposed to complete the programs? And such expectations actually can cause a lot of stress for counselors. The other distress could be working with unreasonable supervisors, or you could call them bosses, and not having good interpersonal relationships with co-workers. When you as a counselor have difficulty or your relationship with your supervisor is it's a bit difficult, the recommendation is actually to set up a time that is aside so that you can speak about your challenges, obviously in a very professional manner. Even in terms of working with colleagues, I know that people are different in terms of their work ethic and in terms of how they view things, but to improve on working relationship, as a counselor, you need to actually be able to speak up, talk to your supervisor about your working relationship with your co-workers so that you can be effective in your job. Sometimes counselors may feel they are not adequately rewarded for the hard work, which is very common in our field, that we often feel that we are doing pro bono. I know Moses did talk about the fact that sometimes you just have to love the work and do it out of the goodness of your heart. And therefore, I would still say there's no perfect job, actually. There's no perfect job. And so for counselors, knowing that whatever it is that you are doing is actually your best, it actually helps to have that self or internal motivation in terms of what you do. For cramped working areas, it could be a source of stress for other counselors. And if you find yourself working in low-resourced areas, like which is often the case in our case, is that you can take breaks so that you don't feel that you are being suffocated in that working environment. Stress can also emanate from the counselor themselves, or himself or herself. When somebody has very high expectation of self, and I would want to ask from you participants, what would contribute somebody to have very high expectation of self? Just one person, just to tell us, why would somebody have high expectation of self? Jessica.
Yes, I'm looking for hands raised. I don't see any yet.
Sometimes, more especially for early career counselors, they come with expectations about what the field is about and what their qualifications is likely to actually do within the work environment, and only to be disappointed sometimes. So that can actually cause stress for some counselors. Having inadequate boundaries about work, this is one of the most important things in terms of SUD field. You have to ensure that you actually, it's very clear the boundaries that you have between you and your clients. In terms of just having boundaries around work, you also need to make sure that you do not take time, your work to home, so that you have clear work boundaries between your work life and your personal life. In terms of just being at work, make sure that you also utilize lunch breaks, go on vacation when you are supposed to go on vacation, and when you are on vacation, do not do work, so that there is that distinction of the times that you are spending with. Sometimes counselors might feel inadequately trained and not competent enough to do the job. And this usually happens when we find our clients maybe not probably attaining the progress that we had hoped that they should, or that they should actually have accomplished. And so it can sort of activate a sense of insecurity about your own training as a counselor. Stress can also come from personal situations for counselors. It could be personal or family illness, new baby. These are transitional transitions in one's life can also pose to be a stress. Interpersonal problems with spouses and partners can also become a source of stress for counselors. Counselors can also suffer from burnout, which is emotional and physical fatigue caused by stress. And this is actually shown a lot by research that burnout is more actually evidenced among counselors and clinicians. Counselors need to find positive ways to maintain their well-being and cope with stress. I want us to spend a bit of time on this exercise. And so I'm going to stop sharing this slide. But what I would want us to just pay attention to before we go to the resource page is that I would want us to share not necessarily personal stresses, but maybe to focus our attention, because we do have time, on professional stresses. Maybe we could also share what are some of the professional stresses that we often find ourselves in, what the professional supports that you have in your different areas, and what strategies do you use to effectively manage your work stress. So I'm going to ask volunteers to share what are some of the professional stresses that they find in working in the SUD field. You can raise your hand.
All right. I don't see any hands yet, but we do have a question in the chat. Ajizwa is asking, can you really not take, oh, wait, someone else chatted. Can you really not take work with you on vacation? If your clients call you in crisis, what will you do?
I would want one of the participants to answer that. because we've talked about crisis. What do we do? Can somebody answer that question?
Yes, I can answer the question, please.
Yeah.
I think the counselor, if since she's on vacation and she has a client that called her for work, she can always refer the client to another counselor so that she can enjoy her vacation.
Yes, I do agree with Fatima that, sometimes creating boundaries is actually very helpful. Even for our clients, we also help them to understand how to create boundaries for themselves. So when they see you actually exhibiting that behavior of creating boundaries, it actually is very good for the clients. The other thing is that sometimes when we find ourselves not demarcating time that is off work, we easily get burned out. That is one of the reasons as to why we need to actually make sure that we practice self-care. I hope that answers your question. So any volunteer to share what the personal, professional stresses are?
It looks like Francisco would like to share.
Yes, go ahead.
Hello? Yeah.
Yes, we can hear you.
Oh, you can hear me. Okay. Yeah. Some of the stresses, professional stresses, like when you have, sounds like a conflict of interest. You are a professional, you have colleagues who have SUDs and their jobs are in the line. So at that point, there's times that it becomes very difficult. The professional bait, and there is also the other person or people that you know quite well. And you again putting them into, you want them to get into treatment, and they don't seem to be motivated enough. Or sometimes they also feel that they know too much about drug use, so it's not like there's anything you are adding to them. So they would want to refuse to get into treatment, yet at the same time, they want their job. So you actually get quite a bit quite stressed on this, because you really want to help them. Their job is also on the line, and they are colleagues, and you are in that kind of a situation.
It definitely can be a source of stress. For the next course, we are going to cover ethical decision making, what to do in such instances. But I'm wondering, what kind of professional support do you have?
Hello.
What are your professional supports?
Well, I'm going to add to the question about professional stress that can arise as a result of practicing your profession. This is Michael.
Yes, thank you, Michael.
Yes, sometimes you find very, unquote, difficult clients who may have complex issues, probably not very intelligent, comorbid conditions, and personal characteristics that are difficult to with. So sometimes they create stress for you because of the extra time and the extra energy you require in dealing with them. And it can be disappointments or frustrations for you. Because you must do.
Yes, and I do appreciate your contribution. Sometimes the disappointments I've seen, even for myself, where I've had clients, I'm working with a client, they've been in recovery for quite some time. I write a report to the PO, probation officer, and then immediately the probation officer gets the report. They go and use substances. And one thing that I've learned in that is that when we learn that our client's journey is their journey and it is for us to support them, it actually sort of passes from or lessens this disappointment that we normally experience when a client sort of lapses or relapses. But yes, it can be very difficult when you are working with very difficult clients, because it does take a lot of commitment and energy So thank you for your input. Now for others, what are your professional supports? Do we have professional supports in this field?
Yes, I would also like to contribute to that.
Yes.
Yes. Normally, we have review meetings where some form of case conference is held, and people bring up cases that are, though every case is unique, but cases that seem more unique, cases that raise difficulty in terms of management and so on and so forth. So then colleagues can make inputs and provide insights to new areas that you can explore to navigate away from challenges.
So case management, I'm getting a sense of case management is one of the professional support. Even clinical supervision outside your program also, for some, actually that's what they do. You get clinical supervision from your site, you also get extra clinical supervision from somewhere else. Now, what are the strategies that you often use to effectively manage professional stressors, so that we share?
I go on.
Hi.
Can I
Yes,
go on?
you can go ahead. Yes, you can go ahead.
Okay. One of the strategies that one can use to manage stress, like you said earlier, one of them is vacation, taking a rest as at when due. Then secondly, don't always do the whole thing yourself. If there is a job that can be shared with others, please let others participate instead of only you doing a particular thing that is meant for 3, 4, 5 people. Let's not take the work too personally. Let's share with others. Let's contact our supervisors so that they can also direct us in what we are doing. Thank you.
No, thank you for sharing. I think this has been stressed. I know Beatrice also mentioned it, that we need to consult, involve other people. Even Professor Moses actually talked about it yesterday and today, that when working within our field, one of the strategies that actually is best is actually to make sure that you consult with colleagues, you consult with your supervisors. And when you are unsure about something, do seek help and seek more information in terms of what to do. So I'm going to move to the resource page. I'm going to stop sharing so that we just look at some of the elements of self-care. I'm going to share the self-care. Can we see the resource page 5.1?
Yes, we can.
Okay, so here for resource 5.1, these are some of the examples of elements of self-care that counselors can actually utilize. Number one, with regards to physical health, is making sure that you eat well, you eat balanced meal. The other one, in terms of physical health, make sure that we go for our physical checkups. I've worked with clinicians, counselors, where they will tell you that they don't even have time to go to a dentist for the whole year. So it's one thing to take care of others and not necessarily take care of yourself. We are only as effective when we are able to take care of ourselves. Make sure that you have adequate time set aside to ensure that you rest and relax. So for the prof who said on vacation, we need that time to rest and relax. Okay, I've just moved it a bit. We also can utilize. Okay, sorry about that. Just moved. I don't know why it's moving like that. You also need personal support system, where you can actually have other people outside your work environment, where you spend more time with, as compared to actually having your colleagues at work, and over the weekend you are still talking about work with your colleagues. Make sure that you also, for your own personal development, you seek therapy. The one issue that I wanted us to also talk about is actually health boundaries that are healthy. Make sure that there is separation between personal lives and work life. A lot of times people within the SUD, because of their passion in terms of their work, they spend more time in work as compared to other domains of their lives. So they do not take time for family, they do not take time maybe for spiritual growth, for physical health. So it's very important to set those clear boundaries. Even with regards to boundaries regarding clients, we would want to ensure that you don't spend time with your clients outside work, so that it does not contribute to confusion for the clients. Because at times when we have this sort of dual relationship with our clients, it can impact our effectiveness in terms of doing therapy with them or doing counseling with them. So you need to set that boundary very straight for yourself and even for the client. For personal support, you also need to actually recognize when you have burnout, and do not be afraid to actually seek help and ask for help when you do need. There are different ways in which you can actually contribute to your own development as a counselor. One is to join a professional association, to work closely with your supervisor, right? And to try to also make sure that you have good working relationship with your colleagues when necessary. And I do appreciate one of our participants who actually mentioned this concern about the co-workers. It does show that you do have a good interpersonal relationship with co-workers, but there is a point where you would need maybe probably also, in view of you taking care of them, talk to your supervisor about what is happening with your colleagues. Exchange ideas for service improvement with supervisor and colleagues. Work on your time management issues if necessary. Participate in all available training, and further your education by reading, which is very important, which is what we are doing right now. The idea in terms of professional development is not to strive for excellence, because excellence sometimes is just an illusion, but to strive for excellence, but not for perfection. Because we work in a very dynamic environment with our clients. So if we're always looking for perfect clients, we'll never get. If we are looking for a perfect job, we'll never get. So these are some of the things that we can actually do to ensure that we take care of ourselves as counselors. Number one, taking care of ourselves as counselors ensures that we are effective in our treatment provision, and thereby impacting client retention, which is very important for us. So we'll stop right here. If there are any questions, I know we have 1 minute, or if somebody wants to add in terms of the strategies that they use, they can share with us. I can't see the chat here. Anybody wants to add in terms of what they do?
I see JT Lope's hand is raised.
Okay. You can go ahead.
All right, I've already put it on the chat. I think as a counselor, we should not be all in all. We should be able to know our limitations, because we are human as well. So in as much we want to assist other people, we should think about ourselves first. because sometimes we are carried away with the job and we don't even think about ourselves, the family suffer because of the job. So we need to schedule our time very well so that we ourselves will not suffer burnout. Because I just read to chat. Fatima was just saying now that she's suffering from burnout, and that is the truth. For example, in my place of work now, I'm the person in charge of prevention as well as treatment. So being here now, I've been to radio stations, to television stations, I've spoken so much today, and I'm here again now, so you can see. But anyway, because we are passionate about what we are doing, so the seal is still there, and we're still, the vigor is still active as well. So I think we should just know our limits.
Yes. No, thank you for sharing. It's very important to recognize also when we get to that point where we get burnt out, because we are only effective when we take care of ourselves. We are only effective to our clients only when we are able to take care of ourselves. So there is a partner exercise that we hope that you'll be able to do when you are doing the training, but you also can actually look at the exercise actually as part of your homework to look at the plan for change. What are some of the things that you feel that you need to focus on in terms of change? How are you going to go about it as we talk about self-care? So that being said, I'm going to ask you to do it as homework. We won't necessarily discuss it, but do take time to develop a personal plan to take care of yourself. So with that being said, this is the end of my presentation for tonight. Okay, now I can see the... So we are at the end. I'm now seeing some of the comments. I couldn't see the comments. Limit number of clients. Thank you for your contribution. I see all the comments in terms of what everybody is doing in their programs. So Jessica, we are now 2 minutes after 8. Beatrice, Moses, we are done.
Yeah.
Thank you. Thank you, Moreko. We are done, actually, not just for your session, but for UTC 7. And we're very excited to be done with UTC 7 successfully. We thank all of you and the trainers and Jessica and participants for yet another success story. And we are now going to take 2 days break, tomorrow and Sunday, after which, come Monday, we shall begin UTC 8, which is an intense curriculum, which will probably take about 7 days. I mean, 6 days, not 7, 6 days, just like UTC 5. So we look forward to a great time of ethics. We will tell you the materials you require before Monday. And then, of course, after next week, we will go to the last week where we will have a day or two of the implementation portion of this walkthrough. So thank you very much. And I now hand it over to Moses to say something to you before Jessica finalizes. Thank you.
Well, thank you for being great participants. Thank you for your patience and your active listening and participation.
Yes. Good night.
Jessica, anything from Kim?
I do know that Kim will be joining you on Monday, so she will likely have something to say as we approach the end of the UTC curriculum that we're going through. And other than that, I just want to thank you guys for being so flexible and adapting quickly to the new system, because the trainers and myself have definitely had our own challenges with it, and you guys have been great. And other than that, I hope you have a great night and a great weekend.
And please remember to do the post-test for UTC 7 and the pre-test for UTC 8. Thank you.
Thanks for the reminder, Dr. Marieke. Thank you very much. Have a wonderful weekend, huh?
Thank you. Have a lovely weekend.